Tonight we're going to talk about cognitive decline. There should be plenty of time at the end that we can answer any questions that you have. So what we're going to take you through is the idea of what is cognitive decline. The first thing we have to do is define some of these definitions. So what is cognition? Cognition is the process of thinking. It's what you do on a daily basis. It's processing your speech, recognizing speech. It's seeing people, recognizing who they are. It's being able to put together your thoughts into a coherent manner. These are all the things that make cognition. So when we talk about cognitive decline, we can talk about that any one of these factors could be affected, limiting our abilities to interact and communicate, limiting our activities to function in an independent daily fashion. Now, we talked about on that little brochure the differences between mild cognitive behavior. We're going to talk about dementia. We're going to talk about Alzheimer's. But we're actually going to start with the definition of what is subjective cognitive impairment. Subjective cognitive impairment is just an impairment that we can do a test on you. We can't see that there's anything wrong. But you feel that there's something wrong. You might be thinking, geez, I'm just not as sharp, I'm not acting as well, I'm not responding as well, I'm not processing information. That's subjective cognitive impairment. Then we go to mild cognitive impairment. Mild cognitive impairment is that process that you're missing a few steps. We usually determine that by a testing. It could be a mini mental state examination. It can be something called the Montreal Cognitive Assessment Form. And these are just some paper pencil tests that we're looking to see if you're able to respond appropriately. And that just gives us an idea of where you are on that scale, whether you're missing some ingredients there. And then we go on to dementia. From a clinical standpoint, dementia is simply not being able to function independently in your ADLs. From an anatomic basis, that could be very different. Alzheimer's, it might be amyloid bodies and neurofibrillary tangles. That's an anatomic examination. For Parkinson's, it could be Lewy bodies. So there's a variety of ways that we're looking at these to determine if somebody has dementia. But from our purposes, we're going to talk about dementia is that you're missing two key capabilities that restrict your ability to be independent in your activities of daily living. So that means you're not able to get up or get dressed or prepare your meals or balance your checkbook or pay the bills or interact with other people, not able to communicate effectively so that you could live independently. That's the definition of, if you're missing some of those factors that put you in that category, we would be, on a clinical basis, discussing the consideration of dementia. Now, there's a lot of different types of dementias, and you can't see this, but just to go over that, you have some dementias that are vascular dementia. You have Parkinson's dementia. You have normal pressure hydrocephalus. You have Wernicke-Korsakoff's, Huntington's chorea. They're all forms of dementia. But the number one dementia that we have is related to Alzheimer's. It's about 7 times more prevalent than the second comer. And the second comer is going to be vascular or it's going to be Lewy bodies. So when we're looking at dementia, we're looking at the anatomic area, and then there's some characteristics between the different types of different types of dementia that lead us into the consideration. Most of the time today, we're going to be talking about mild cognitive impairment, subjective cognitive impairment, and then leading into Alzheimer's, since it's the most common thing. But, and this is just an example of what Alzheimer's is affecting primarily. Alzheimer's seems to preferentially affect a part of the brain called the hippocampus. That's the colored area in there. And the hippocampus is responsible for memory. Okay? So let me ask you, let me find out from y'all, let me get to know you a little better. What is it that you would like to know from this discussion that we're going to have tonight? Anybody brave enough?
All the things we could do to try to prevent it.
How to prevent it. Perfect. Anything else?
I guess what I call the getting older forgetfulness, trying to separate just kind of forgetting stuff from
a real pathology. Is that right?
Yes.
So his concern is, how do we determine whether we have a real pathology or it's just aging? Is that right?
Yeah.
Okay. Anything else?
Are there any drugs or vitamins that you would recommend?
Okay. Are there any drugs or vitamins? That's a very good point. You're going to see some stuff on that. Yes.
What could be normal aging dementia versus seeing a loved one that had radiation to the brain, and what is kind of common with that?
With
trying
radiation?
to decide between the two.
Yeah, I may not be able to answer all of that, but we'll try some.
You look at foods we can eat, natural things we can do, so we don't get this, because you don't have to get this. It's not something you have to get. This isn't natural aging. I disagree.
Okay, did you hear that? So she is in disagreement that you have to get this with aging, and she wants to know what kind of foods or nutrients you can take in.
Right, because there's lots of cutting-edge stuff out there.
There is.
How do we deal with that?
How do what?
How do we deal with dementia once we know it's there?
Once we know, what do we do with it? Tough one.
I have a loud voice. Along the lines of the radiation, are you aware of the connection between surgeries with anesthesia and then kind of losing some of your marbles, at least for a while afterward?
Okay, we'll bring that up just a little bit as well. So, one more question.
Does all kinds of dementia go up on these tests? Because sometimes I think observations are important too.
Yes, I think that she has to are we dependent upon the test to determine dementia, or can we use observation? Is that fair enough? Yeah, and you will see, as we talked about right here, the diagnosis of Alzheimer's is actually an anatomic test. That means the person dies, you take their brain, you look into it, and you find out if they have amyloid and neurofibrillary tangles. That's kind of too late. So the definition, the clinical definition of Alzheimer's of of dementia, is we are at mild cognitive mild cognitive impairment until we reach the state that we lose our independence. Does that make sense? So, that wasn't there. So, we're going to try to answer those questions. If I'm not answering them, I want you to talk to me about it. But let's just tell you what our incidence is. So in the United States, 30 million people, 2012, associated with dementia. The majority of those are Alzheimer's. We're expecting 160 million by 2050. Women, unfortunately, kind of get a bad mark in this, because the majority of individuals that have dementia are women. And it's almost considered a contagious disease, because the caregivers of the individual with dementia have a higher incidence of dementia. Alzheimer's disease, look at the cost. It outranks cancer. It outranks heart disease in the cost. So should we be concerned about it? I mean, already are we in a healthcare crisis? Can you see where we're going? So we ought to cure it, right? Or we ought to get rid of it, or we ought to do something about it. And that's how many cures we have for Alzheimer's. Now, you know there's got to be something else here, right? I mean, we're early in the talk. I give you it's like reading a book. I remember reading this book. Anybody read Shogun? So I'm reading the book, and you're reading along, and then suddenly that main character that we all fell in love with just died. Didn't you want to just put that book down? Stay with me. There's going to be some other stuff we're going to talk about. But so far, we don't have any medical cures. There is not one drug that's been made that's effective in treating Alzheimer's. So why did I say that there's some new developments of things that we can do? Well, how do we treat that? Well, let me just introduce you a little bit about myself here. So I have two forms of medical practice. I'm a medical doctor. I have one form that is called Bozeman Sport Spine, and I deal with musculoskeletal injuries, trying to avoid surgical interventions. We're basically more so a restorative and regenerative practice. We do a variety of things trying to help people with their joints and their muscles and their tendons and their ligaments to restore their physical health. We do stem cells and PRP and prolotherapy and alpha-2 macroglobulin injections. We're kind of on the cutting edge of that. But then I'm talking from a different framework as well right now, and that is from Fresh Start Health and Wellness. And Fresh Start Health and Wellness is more of an integrative, holistic practice. So my background, in addition to being a medical doctor, I'm also board certified in integrative medicine. I think I'm the only physician in Montana that has that board certification yet. I'm a member of the American, a diplomat status with American Associated Integrative Holistic Medicine. I just completed my certification in functional medicine. I think I'm one of two practitioners now in Montana that has that. And I'm working on my fellowship in American Academy of Anti-Aging Medicine. So the concept here, what I'm going to come to you from, is an idea that we have to look outside the box when we're going to take this. And so the question is, how do we cure or how do we address Alzheimer's? We know there's no medication to cure it. So we're going to have to look outside the box. And I told you about those concepts, about the things that we're looking at. And now we're just going to go through some of the ideas to give you some understanding about some of the things that we have to look at when we're addressing Alzheimer's. Because we just told you what your clinical presentation is. But how do you get there? So, in the 21st century, I think that how we have to address that is we have to be not only look at the traditional medical approach with all the benefits that medicine has, understanding bench science, understanding anatomy, understanding physiology, understanding the medications, understanding the drugs, but then I think we also have to step out of that role and look at traditional medicines. Look at the value of sleep, the value of nutrition, the value of exercise, the value of hormones, the value of social community. And I think as you look in medicine and you look in the health, that's where it's going to have to come down to as well. We can't rely only on one, but we can't shun the other one as well. So hopefully in the 21st century, and to address the issues that we have, hopefully we're going to have more practitioners that are willing and accepting and want to work with the more traditional type of medicine to incorporate that into a way of solving some of the issues that we now face. That's my expectation. So how do we get Alzheimer's disease? Anybody surprised? Alcohol contributes to Alzheimer's disease. How about Benadryl? How about proton pump inhibitors? How about anticholinergic medications? How about air pollution? Small particles. How about sleep? Now, these are all articles They're in the journals. They're in the literature. We can all read them. And they're doing the studies and looking and seeing what is associated with it. So sleep affects it. Sugar, artificial sweeteners, vitamin D, vitamin B. PUFAs, is polyunsaturated fatty acids, have an effect. The Mediterranean diet, have you heard of that? Diet and nutrition has an effect. This is a positive effect, not an effect to avoid the Mediterranean diet. Ketosis, has anybody heard of ketosis? It's been around a long time, right? It got a lot of slack for being around for a long time. Then we look at oral infections, gum disease. And I'm sorry, I have to keep looking because my screen is so small. So hormonal therapy. Estrogen. Low estrogen can have an effect on it. You know, there was a study with the Mayo Clinic looking at women that had hysterectomies by the age of 40, had a significant increased chance of developing Alzheimer's disease. Vitamin D. Testosterone, by the way, if I didn't put that in there, testosterone has an effect too if you're low in testosterone. Homocysteine, folate, other inflammatory conditions, and homocysteine is a big one. Copper toxicity, diabetes, cortisol. What's cortisol? It's a hormone, right? And it's released with, you're saying, stress, right? And you know what part of the brain has the most significant receptors for cortisol? That part of the brain called the hippocampus. That part of the brain that is most significantly affected by Alzheimer's. That part of the brain that is responsible for memory. Adiponectin, lectin. These are all hormones that have to do with our weight. So there's a variety of, sorry, those were hidden slides, but I guess they still show up. Interleukin-6, which is an inflammatory and C-reactive protein. So if we have elevated markers, we have a higher association with that. Just inflammation in general. And these are some of the markers for inflammation. And these are things that you can check on a regular blood test. Then we go to tumor necrosis factor, again, on a regular blood test. We go to vascular involvement. And then we go to viruses. Did you know that when they look in the brain of some of the people, sometimes an antibiotic actually helps somebody that has Alzheimer's? And you start to wonder why. Should we give everybody an Alzheimer's? And then in some of the anatomic slides that they look at, they find various bacteria, fungus, viruses caught up in the amyloid. Herpes virus, cold sores, gingival bacteria from your mouth, from your gum disease, Lyme disease. So that's our brain. That's a healthy brain. And the other brain is a brain that's losing. You see that hippocampus area, and then you see the hole there, and we're losing it. That's the brain that is becoming degenerative, that is losing its capability.
Is the hippocampus in the center where the holes are?
The hippocampus is this line right there, and the holes are ventricles that carry the cerebral spinal fluid. And the cerebral spinal fluid, as you lose brain matter and the brain matter shrinks, the holes get bigger. Does that make sense? So, what do we do? Now, why did I bring this up to you? I brought this up to you. I brought this, some of the slides, and there's a lot more information we give you, is that there's a lot of different factors associated with Alzheimer's. A lot of them. And a lot of those factors are associated with your lifestyle. And so much time, the problem that has happened with the drug therapies that have been out there is we're looking for a way just to get rid of the amyloid. And we're not looking at the reasons why we developed the amyloid, why we developed the pathology in the first place. And I can go over that later, because it's a little technical, but it's not that bad. And if you want to, the questions answered, we'll go over that. But what we're talking about is that amyloid is produced by 3 different mechanisms on the body, in general. One is inflammation. If you have inflammation in your body, we are contributing to a problem. Not just your joints, not just your back, but your brain. The second one is the withdrawal of trophic support. Trophic support is, think about it as what helps make something grow. If you have a plant, what do you have to give it? Yep, nourishment, right? Sunshine, right? Water. What do you have to give our brain? Well, so far what we saw was vitamin D, right? We saw sleep, right? We saw B vitamins, correct? We saw sugar, maybe not so much. We saw a good Mediterranean diet with good healthy fats, right? We saw hormones, correct? Testosterone, estrogen, they all act in their trophic support to help in supporting the brain. And then the third consideration is toxins. Chemicals. Things that we run into our environment. Okay? So those chemicals can be mercury, those chemicals can be pollutants, they can be pesticides, they can be herbicides, they can be a variety of things. Does that make sense?
Did you ever say what amyloids are?
So amyloid is, yeah. Let me answer that in the question at the end. Okay? Amyloid is an interesting thing.
Bad thing. We don't want that.
Yeah. Yeah, basically what amyloid does is when we make amyloid, how a brain functions is you have a thought or you see something. And there's a series of connections that occur for that thought or for that visual experience to happen. So that impulse comes into your brain and it hits a neuron, and the neuron is a cell. And that cell has all kinds of finger projections going all over. And so it hits it to that cell, and that cell connects to another cell and connects to another cell, and it creates an image. Now, I'm not even sophisticated to know how a tape recorder works. I still think that's kind of a miracle. You get that tape recorder, you talk into it, you know it's a magnetic strip. They've told you it just records pluses and minuses. But how does it know what my voice is supposed to sound like? But that's what it sounds like. My voice when I listen to it back. So that's something simple. God created something incredible. Something so much bigger. So we don't understand all the concepts, but we don't understand all the specifics, but we know that those connections happen. And we call those connections synapses. And the longer you have a synapse, something that helps support that response to that nerve cell, then we maintain that in our memory or our function. So the consideration is, if we produce some other substance that gets in between those connections and prevents that connection from happening from one cell to the next cell, it's kind of like we just put roadblocks in there. So now we have to take a lot of different avenues. Does that make sense?
So the amyloid is
So the amyloid is a protein. It's a protein produced by the body, and it's produced by the body as protection. So we think it's evil, but it was made there for protection. And I'll explain why later. Okay? So when that cell interacts and how these processes act, if you're under fire, if you're under attack, if you have inflammation, if you have lack of trophic support, your brain wants to protect itself. And so what it's going to do is, in a sense, those neurons are going to start to withdraw. And so new memory that occurs, new synapses that are developing, it won't make that synapse thick. It's going to take that material that connected the synapse and recirculate it, take those chemicals away because you don't have enough in your body in the first place. There's an inflammation. It needs all the energy it can to fight the inflammation. There's an infection or some kind of a chemical that's causing a problem. It needs to round the wagons to protect what it's got so that you can remember how to chew and how to breathe as opposed to spending time on new memories that develop. And so it withdraws from that. And so the heralding mark of Alzheimer's is that initially you remember old things, you just can't make new memories. We ask you to remember something, you just don't get it. And as it progresses, then we'll start to lose the recognition of other people's faces. We'll start to lose the recognition of things that we've known all along. We can't hold a calculation in our mind long enough so that we can add something to it. That's how it develops. Does that make sense? So, now we have an idea about what are some of the contributing factors to it. We talked about the nutritional factors. We talked about some trophic factors. We talked about infection. And here's the bugger. Here's what we find out. It's not one thing. So far, they have found about 36 different elements that are important in the development of Alzheimer's. Now, we all have a genetic difference of us. Some of us aren't bothered by some things that other people are. And so some people may respond more acutely to fewer number of insults or fewer number of these events. And others, it may take a lot. Does that make sense? So when we finally get to the point of developing to Alzheimer's, we've gone through that point that we've kind of lost our reserve. So when we talk about subjective cognitive impairment, that's about 10 years or so before we run into some testable cognitive impairment. Doesn't mean everybody's going to get it, but in general it's about 10 years. Once you have mild cognitive impairment, not everybody goes to Alzheimer's. Maybe 50%, maybe 5 to 10% of those people per year. And then we're in our course for Alzheimer's. So what we want to do, if we're going to develop these things, what we do want to know is we want to start working with identifying the factors and the deficits that we have and trying to correct them. Now we have different types of Alzheimer's. Type 1, type 2, type 3, type 4, type 5. Type 1 means there's inflammation. We relate that type of Alzheimer's more to inflammation. Why do I even say a type? Well, it helps me in kind of sorting out how we're going to go about treating that. Because when we do the test on somebody, we might do blood tests, and we might look at some of those other factors, and you find out that that person has more inflammation. How do I calm that inflammation? And no, it's not an aspirin and it's not ibuprofen. We have to get to the source and take away the inflammation. Then we go into the non-inflammatory, that's more the trophic type, that's type 2. And we're looking at what are we missing into the nutrients. Maybe what is your zinc level compared to your copper level? What's your vitamin D? And we hear a lot about vitamin D. And I'm criticized sometimes because I like people on vitamin D. But vitamin D is important for your brain. Vitamin D is important to decrease your risk of diabetes. Vitamin D is important to prevent or address autoimmune conditions. Vitamin D is important to prevent, or there's association with lower levels of vitamin D and higher incidence of cancer and cardiovascular disease. So sometimes when we look at a value and we're looking at the numbers, we don't necessarily want to look at the normal range, because the normal range of vitamin D goes from 30 to 100. 30 is fine, right? Depends. Depends on what condition you're trying to prevent. I look at 70 to 80. Because I get more bang for my buck out of more conditions that I'm able to prevent. Now, should it be monitored? Absolutely. Not just, here's your vitamin D and you're done. Then they put in a category type 1.5. Type 1.5 is the category that we talk about type 3 diabetes. Has anybody heard of that? So they talk about Alzheimer's is related to diabetes, and they've related, big article, I think it was in Time magazine, about inflammation in type 3 diabetes. It's related to insulin resistance. You see, the interesting thing, it's kind of between a 1 and a 2. So it's a 1.5. It has inflammatory components because when your sugar levels are elevated and your insulin is high, that's inflammatory to your body. That causes inflammation. That's why when you eat and they talk about saturated fats, listen, I might get arrows at me, but saturated fat by itself is not such a bad thing. But when you add sugar to it, that sugar inflames your blood vessels. And it causes oxidation of that fat, which now sticks to those blood vessels. And now we have atherosclerosis. Make sense? So if you're going to eat, make sure there's plenty of fiber to pull things out. Don't eat sugar with your saturated fats. And maybe just get a better saturated fat. A better fat. But we have to come back down to looking at what we're after on this. Does this make sense? So too much sugar, too much insulin are inflammatory to our body. But if we don't have enough nutrients, if we don't have enough sugar in our body, which is like 15 grams a day, and we don't have enough insulin, those are trophic responses. Those help with the nourishment of a cell. And when they're going to grow nerve cells in a beaker, they add insulin. Not too much. The other consideration is this, is that there is a factor called insulin degrading factor. And we need that, right? Because when you have insulin, you don't want that insulin circulating in your body the whole time, because insulin takes the sugar out of your blood and puts it in your cell. That means every time you're trying to get any sugar in your blood, it takes it out. And you're always hypoglycemic. So we have to have something that degrades the insulin so it gets rid of it. So we have something called insulin degrading factor. Do you know what else that insulin degrading factor does? It degrades amyloid. It chews it up. It kind of gets rid of the problem, maybe. So if our insulins are too high, we're spending all of the time with the insulin degrading factor, at least that's some of the research, and we don't have enough left to get rid of some of the amyloid that's developing. Then we go into number 3, toxic, vile. Those are chemicals. Those are substances. Those might be mold toxins. That's the tough one. Then we go to 4, that's vascular. We have a little machine back there, and I was late to go or anything, but we have a little machine. And in our office in Fresh Start, we use a little machine, and it's called a plethysmography, and we put it on your finger. And we measure how that pulse wave goes through your finger, and it gives me an idea of very early vascular problems. So that we can now say, whoa, we have an idea where you are, let's try a therapeutic on it, and we test that in a while and see if we've improved it before we run into the end. Does that make sense? The earlier you treat it, anything is better. So vascular disease causes it. And then the last one is trauma, head injuries, concussion, higher incidence, higher relationship to dementia from that condition. So these are some of the characteristics of type 1, of type 2, 1.5, and type 3. So the age of onsets. Type 3, oftentimes the age of onset is going to be, oftentimes can be low as the 40s or the 50s. So when the World Trade Towers went down, there's a significant increase in some of the first responders for cognitive dysfunction, and we think it's related to some of the chemicals, the mold, the toxins that are involved. The differences are, remember we talked about your memory. So those first 3, meaning the inflammation, the diabetes, and the trophic, all affect the hippocampus first. Because people are wondering, why do we have all the characteristics of amyloid, and we don't have to wait till the person dies. We can do imaging studies, PET scans, amyloid PET scans. They have a better one that's more accurate called the tau PET scan. It's not done anywhere. A lot of times they're just in research facilities. We have something that we call, however, that can work very well, is you can do an MRI scan and they can do a quantitative analysis of the size of the structures. So you get an idea, is your gray matter shrinking? Is your hippocampus shrinking? Are your temporal lobes shrinking? Which have different effects. So when we look at type 3, you notice that amnestic, or your memory, is not the big thing. It's a variety of places. It's not only on that memory. And we find that same incidence with trauma, head trauma, and we see that same incidence with vascular. So, non-imaging studies, these are some of the studies that we might look at. And this is just some of the laboratory studies you can get in any lab. We look at your thyroid function, because if you have low thyroid, you're not providing the support to the brain. If you have, if your testosterone's low, your estradiol's low, your nerve growth factor, your vitamin D. I didn't talk much about brain-derived neurotrophic growth factor. Have you all heard of that word? It's kind of, yeah, brain-derived neurotrophic growth factor. That's BDNF. BDNF is a really interesting substance because BDNF helps support your ability for the health of the neurons, which is a brain cell, and its ability to make connections. So BDNF is also important in terms of when you activate your muscles for the health and the growth of the muscles. And so we find that when people exercise, they increase BDNF. Anybody heard of curcumin? Increases BDNF. That's one of the things we do. What is curcumin? It's an herb, right? It's like ashwagandha. It's like the Indian ginseng. It is turmeric. And so what it does, it has an effect on our brain, it has an effect on our gut, it has an effect in so many places of our body. It's kind of like aspirin in a way. You know, aspirin is good for everything. But turmeric is kind of that same way. And you know what else stimulates BDNF? Intermittent fasting. So when you give your brain, through your body's reaction, the energy that's required to digest and process food, because you've all heard of oxidation. You know what oxidation is? Oxidation is you have like oxidation, oxygen, and there's a release of electrons that may be too many for what you want, and they're floating around and they get into other places, they cause havoc. Every time you eat, there's oxidation. When you cut a pear, when you cut an apple, and it goes from white to brown, that is called oxidation. So if you put some vinegar on it or vitamin C, it doesn't do that, does it? Because vitamin C is an antioxidant, along with vitamin E, if it's the correct form of vitamin E. Because you know there's 8 of them. So when we're looking at these different types, these are just some of the markers that we might look at to determine where you are and then what we're going to do with it. So here's the research. Research is that inflammation is a protective response, or Alzheimer's is actually a protective response to your body. It is trying to protect you from what we are doing to it. Now, why would I say that? What research do I have saying that? You know, it's interesting. Anybody heard of an ApoE4? One person? So, we wonder what our role of genetics is. We talk that we have a different capacity to deal with things, right? We have a different capacity to deal with stress. We all look different. We all know that we have different genetics going on. But the number one genetic factor that seems to be associated with Alzheimer's is an ApoE4. And it's interesting, they did this study, and they went down to South America, and they went in the back country, and they looked at this group of people that had ApoE4, which predisposes you potentially to Alzheimer's. It gives you a much higher potential for developing it. And they found that group that had ApoE4 had less Alzheimer's. And they also had parasites and other things. So ApoE4 was designed to protect us. It is allowing the body to mount a more significant inflammatory and protective response for the brain to protect it from parasites and other organisms and get into the brain. And it walls them off with amyloid. And it keeps them from affecting the entire brain. And they found that the people that had ApoE4 that didn't have an infection didn't do as well. Interesting, isn't it? I'm not saying ApoE4, you should go get an infection in your brain. What I'm saying is, it's an interesting thing when we start to look at the mechanisms of what happens. And so, the concept here again is that we're looking that we want to restore the trophic response, we want to get rid of the inflammation, we want to find out the different toxins that might be involved in the body. If it's a vascular consideration like that test, we want to find out what we could do for vascular disease before we say, yeah, well, you got a coronary calcium score of this, it's kind of late. Or you have a lot of white spots in the head. We want to try to address that and see what we can do to improve it. And that head injuries, just do not play soccer if you're a girl. Okay? Because there's a lot that I think the number one incidence for post-concussive syndromes is now in young ladies that are playing soccer. Interesting, huh? All that heading. So what do we want to do? We want to identify the type. How do we do that? A variety of laboratory studies. We want to identify the offending pathology as much as we can. Laboratory studies, interviews, find out what's going on in your life. We want to individualize a program to treat you. We want to address those things. We want to make sure that you're sleeping 8 hours a day. We want to make sure your vitamin D level is good. We want to look at your homocysteine level and make sure it's below 6. You know, it was below 8 for cardiovascular disease, but I guess the brain's a little more sensitive. It works better below 6. We want to look at your intake of fats. And we might want to put you on a ketogenic diet, because a ketogenic diet is protective of your brain. The ketogenic diet means that you're not burning sugars as much. You're burning fat. We might want to look at your activity level, because we know that when you exercise, you increase your BDNF. We want to look at inflammatory markers like TGF-alpha, NF-kappa beta, so that we can see where you are in those inflammatory markers. And then if we can't get you better, if we're working on things, maybe we got to look and see if you have any mold exposure or other things going on that could be addressed. Does this make sense? So I'm going to leave it for questions now. So the questions that were asked to me that I didn't go to, can somebody just say one of them that I didn't explain yet? We'll see your memory, okay? It's a memory test. Yes.
I've got a new question. How's insurance reimbursement for those tests?
That's a good question. I don't know. Yep. You know, it's kind of tough somewhat, because some of these tests may be out of the ordinary. But seriously, we're dealing with a disease that there's no cure. And yet there's indications that that these issues contribute to the problem. And it's not just me saying it. It's seeing people that have gotten better from this. And so, for instance, we're doing an estradiol we want to know, or we're doing, we want to get TNF-alpha. And I really don't know on that. I'm always scared a little bit, because a lot of people think we all ought to be under a single healthcare system. And several years ago, I got a little thing in a little letter saying we are going hard after Medicare fraud. I says, go get them, those scoundrels. And then I read what they were saying constituted Medicare fraud, which was you're ordering a test, you're having an appointment about something that we don't think, basically, you needed to do. It's concerning. So, we don't know. Yes, sir?
Earlier I asked, just, old, I'm now retired, I'm not, working as much, I'm not using the noodle as much. I find myself a little more forgetful of things, that type of thing. Okay, how do you know that it's just getting a little older, or what I call CMS, can't remember shit, versus a...
Isn't that medical? Medicare's initials too? Okay, sorry. Yeah, so what do you do? So his point is, how do you know? Is it just normal aging? What do you do? And I guess I'm going to come back to you and say, what is normal aging? What should our brains be functioning? Should we expect that our brain should go downhill? There was an interesting study, and this is kind of very interesting to me. There was an interesting study, and we don't know exactly why, but the study took a group of nanotarians, I guess, 90-year-olds that were functioning very well, very good. And they looked at their brains, and they had a significant amount of amyloid. And yet they were functioning really well. So why was that? I think if we want to know, probably to test. I'd do some cognitive evaluation. There's a couple ways of doing that cognitive evaluation. One is to punish yourself, like flogging. Not really, but it go through a formal neuropsychometric testing. I hope I didn't offend anybody. It's an extremely comprehensive evaluation that's the best, okay? But it wears you out. The other thing, there are some good testing tools out there that can be tested. And then maybe follow that and see where you score. So for instance, on the Montreal Cognitive Assessment Form, if you score, it's a score up to, say, 30. And if you score 25 to 30 or even a little lower than that up, it's just mild cognitive impairment. As long as you're not burning the house down and doing other things that you're limited in your abilities of ADL activities. Does that make sense? So there's some pencil and paper tests that can be done, and then that's how we would follow the progress and the improvement of someone anyway on the program. Does that make sense? Yes, sir.
Given all the variables, collectively you have to develop a profile for each individual, correct?
Correct.
So once that's established, it seems to me that we would need to develop a profile from birth to follow through the development of Alzheimer's or these degenerating cognitive processes. So how do you have enough time to profile every individual out there that's headed in this direction? I mean, how do we do that? I mean, where is your work or others collectively headed in that, in regards to that question?
Okay. So I don't think you never, if you wanted to be healthy, we would probably start from birth. Okay. And to be honest, from a traditional medicine, that's what you do. But it's not just for Alzheimer's, it's just for life. I mean, this is controversial. And I don't mean it to be that. First of all, let me just say the genetics and things that happen to us, our bodies, our person, God gave us an incredible being that has a capability of adapting and improving and restoring. That's why we all have stem cells. That's why we have these backup mechanisms to occur. But the longer that we keep a bad attitude about our health, the worse things get. So if you start early and talk to people, and I would love to talk to women before they're having a baby, and before you get pregnant, let me give me 6 months to get rid of stuff that's in your body. And they may say, oh, no, that doesn't happen. Well, okay, maybe it won't happen for a lot of people, but there are some people that may be more susceptible to that. So susceptibility is one. But in terms of when or where would you do the testing, I think that when you're about 45, you probably go through an evaluation. You probably come in to see your doctor and you say, can you make sure I'm as healthy as I can? I want to be healthy. I mean, you're in charge of my health in a sense, but I know it's going to take you more time. I don't think you could do this in 15 minutes. So it's worth it to me to have a relationship with you so we can find out what's been going on. Have I been exposed to any chemicals? Am I spraying the weeds? What have I been eating? Why do we say gluten's bad for you? Is it? Why are we concerned about the gut? So if at that point, and a person that I respect a lot, he coined a word, now I can't even remember the words. It's like colonoscopy, but it's not colon. It's cognoscopy. So you do a cognoscopy. You look at somebody's cognitive functions, their behavior, their function, and you kind of see where they are and say, okay, let's start maximizing this. Because the materials that we're talking about, it's not a pill. It's that other approach. We want to use modern medicine to fill it out. We want to use modern medicine to find out if somebody has a thyroid problem. We want to use modern medicine to find out if somebody has a tumor. We want to use modern medicine to find out if they have a deficiency of something. And then for those things that we might be able to affect, we might want to say, ooh, what can we do to help get your homocysteine down? And we have to understand what homocysteine is. And homocysteine is just a reaction from the body when it metabolizes food that you go into a methionine cycle. And the methionine is converted to homocysteine. Then it's converted back out to methionine. But if you don't have an enzyme in there that's able to methylate it, you're stuck with homocysteine, which is an inflammatory in your body. And so maybe what we have to do is give you folate, vitamin B12, methylcobalamin. Maybe we have to do those things. And if we can't get it, maybe I have to give you a methylated group. And if I can't get it with food, maybe I have to take away some of your food. Does that make sense? So it is complicated. It's complicated. But it's doable. See, that's the thing. It's complicated, but it's doable. And it's not to the point you can say, okay, just give me the thing, I'm done. Don't have to. No, you retest. Does that make sense? It's adjusting, retesting, coming around. And the thing that I'm encouraged about is that it's an option that has promise. It's an option that we can improve something about ourselves. But this is not that option, doctor, fix me. It is that option of saying, doctor, teach me, coach me, help me live a better life. Does that make sense? Yes. He was first. I'm sorry. Go ahead.
You talked about intermittent fasting, and when you talk about that, I'd like to know time frames, 2, 3, 5, 7, 30 days. I had witnessed this firsthand. A good friend of mine had been chronically sick for probably 20 years, reoccurring lung infections, and he went to every medical center around the United States he could to try to get better, and he never did. He finally picked up a book by Paul Bragg on fasting, and that became his Bible. He fasted for 30 days, just water. It cured him. He hasn't been sick now for 5 to 7 years, and I was all at once going, wow, that's incredible. That was one of my questions. The second question is, how does a vegan-style diet help with the Alzheimer's, getting it or not getting it? Has it been shown to have an effect?
Well, okay, so on the first question, the fasting that we're talking about, there's different methods of fasting. So you can fast 1 day a week, and you can fast 2 days a week. I've never recommended 30 days in a week or 30 days. But generally what we're looking at, and it depends on the type that you have. So, for instance, if you might have an ApoE4, we may change. We want to maybe put somebody on a ketogenic diet. But if you're ApoE4, we're going to change the fats that you're going to have. And we want you maybe to be in a little more ketosis. And so for the fast, it might be 12 hours fast. And what's a 12-hour fast? What's the last time you ate? When did you eat last? Okay. And who didn't eat? Good. So just don't eat till tomorrow. I'm sure you're going to get your fast. So if you stop eating at 6, you don't eat again until 6. 12-hour fast. That gives you the chance for your body to recover. Does that make sense? And some may be more. So it is a intermittent fast to give your body a rest. For this type of a condition, there's different conditions you do other things. And your second question was vegan. So This works fine if you're a vegan, or works fine if you're omnivore. Everything has a little different bent to it. You know, if somebody's really strictly vegan, they're probably going to be a little more vitamin B deficient. You have to watch vitamin B. So, and that's a concern. That's a factor, right? But even when you're on a ketogenic diet or on a paleo diet, because everybody knows what paleo is, right? You know, it's funny. When I was working on my degree in exercise physiology at the University of Utah, just a few years before that, the guy that was ahead of me is Loren Cordain. Do you know who Loren Cordain is? He's the guy who wrote the paleo diet. He's an exercise physiologist, University of Utah. Donate money. So so when we're looking at the amount of protein that you're eating, it's still what we're honestly looking at. That's more of a condiment. Even on paleo, the vegetables should outweigh it, because the vegetables have your nutrients. Okay? So it's okay, and I think a vegan is a very good diet, but you do have to watch for protein. Yes, sir?
I think you packed about 600 sophisticated factoids into 60 minutes, and it's going to take me a lot longer to sort that out. So I'm hoping to come back and visit with you after I read the primer, that I need to just put this into a comprehensive framework for myself, because it's too much. And I'm an RN, so I have an idea about chemistry and nutrition and things like that. So, but I'm very interested, but I'm wondering if you can name a book that the Paul Bragg book sounds like one I'd be interested, but one that's more comprehensive, that covers all of the things you've discussed today.
I don't know of a single book that has done that. I'm sorry.
How about one that's close?
No, I don't.
How about one that's... What's the first book I should read?
I don't know. I mean, I have a variety of books in my library that I'm looking at all the time. So if we're talking about fat, I might read Mark Heyman's book on fat. You might read somebody's book on sugar. I forget the name of the guy. I don't remember names. This is more from articles and recent stuff, and I don't have necessarily a book that's going to tell me. It's more going from lectures. I'm always at lectures. I'm always at meetings. We're always talking about what are the best ways that we can do something to bring somebody's health up to a better place. And cognitive, I have two things that have really struck me. One is joints. What can we do to restore joint function, short of a total joint replacement? So that's why we talk about alpha-2 macroglobulin. You can read that. That's why we talk about stem cells. That's why we talk about platelet-rich protein, or plasma, rather. These are all things that affect that. And then when we go to this, cognition is that other thing. So it's accumulation of articles. But as you saw, all those articles, those are just articles. And you can pick those up. And an easy one is just go to PubMed and click in Alzheimer's. Sorry. And I'm sorry, was this too much for you? Some are yes. So
have you heard about the Australian and New Zealand studies, whatever they've been doing about ultrasound, giving patients ultrasound breaks up the plaque in the brain?
Nope.
They carry the ultrasound with them. They take it home. I don't know how you don't zap yourself too much, but you haven't heard that?
No, I haven't.
That's a good one. What about things like coconut oil?
So coconut oil is a saturated fat. Remember how you weren't supposed to eat popcorn from a...
It's a plant-based saturated fat. It's healthy and has lots of good things in it. You're going to tell me it's bad?
Remember that you weren't supposed to eat popcorn from a movie theater?
You're not? Why?
You remember you weren't? Did you ever hear that?
No.
Yeah. And do you know what kind of oil that was? Coconut oil. So coconut oil is an interesting oil. Coconut oil is it's a saturated fat. We seem to find that it's a good saturated fat. And as far as coconut oil goes, a lot of times for the induction, if we want to get someone into the ketones, we might use something called a medium-chain triglyceride. The reason you use a medium-chain triglyceride is that medium-chain triglycerides, or fats, require certain chemicals, in a sense, like chromium, to bring the fat into the cell. And so if you're depleted of chromium because maybe you got diabetes or you got a lot of anxiety and cortisol's high, you'll deplete yourself of those. And then when you eat the fats, you can't get it into your body. But what we find is medium chain triglycerides don't need that transporter. So they can go straight in, provide energy for you. They don't need a transporter. And the ones that we use don't have any taste.
Is that about coconut oil? You're lost.
Medium chain triglycerides. You were talking about coconut oil. Yeah.
It's supposed to be very healthy. There's a woman doctor that gave it to her husband because
right.
And when he didn't have his 2 tablespoons in his oatmeal every day, she noticed it.
Right. So there's a woman that is a neonatologist. Her husband developed Alzheimer's in his 40s or early 50s. And she went all over and tried to get him into all the different courses and studies to look at new drugs that could do it. And she was having a hard time doing that. And she researched on her own, and she found out that there were... well, she found out that the drugs that they were using were based on medium-chain triglycerides. And one form of medium-chain triglyceride is coconut oil. And so she began giving coconut oil to him, and it helped it. What I said is it depends on the type. And so coconut oil is good. Medium-chain triglyceride is a form of coconut oil. And there's a lot of good things about it.
So when we want to do all these good things, like this man over here that's worried about his health and his becoming, instead of worrying about if you're becoming anything, why not just do everything that's good for yourself and not worry about it? Why not just eat really healthy, get all that exercise? Why not? I've just read that.
So that's the summary slide.
Why not just do what's good for you and not worry about what degree of whatever you have is? Like this lady that I just heard about, she wants to turn you from a sugar burner into a fat burner. Because when we're fat burners, we're going to be less inflammatory. We're going to be all kinds of good things. Whereas if we're only relying on sugar, that's not healthy, right?
Yes.
So we want our bodies to be fat burners. So how do we do that? That would be really important.
Yeah, and that's a little beyond what we're going to talk about right now. But yes, it is. And your point is good. Why don't we just live healthy? I agree 100%. Just be healthy, okay? But sometimes just being healthy may not make it, or we're wondering about, am I really healthy? And that's sometimes if you took vitamin D, and I said, geez, I want you to take 2,500 units of vitamin D a day. And you go, I'm taking it, I'm healthy. And I check you and I find out your bones are really painful. And I check your vitamin D level and it's 28. I say, don't think it was enough. So we do labs to help us figure it out.
Right. You can have too much and you can be toxic vitamin D. Right? Toxicity.
Yeah, we got to figure out what that is, but yes, you can. Any other questions?
I have a question on a basic question about amyloid. And I know that there's PET scans. I don't know exactly where they test for it and go to treatment. But does a brain MRI or a brain scan necessarily show amyloid?
No. So to show amyloid, you need what is called a PET scan. And a PET scan is a special kind of a scan, and they have different types of PET scans. They have an amyloid PET scan, and then they have, I don't know, to be honest. And then they have what do you call it? The tau PET scan. But this is the important thing. I guess this is as much of a take-home as anything else. And I really think this is important. Number one, your genetics do not determine your life. Number two, a diagnostic study doesn't determine your life. We talked about the people that were 90 years old and had all over had amyloid, and they were functioning very well. Now, is there something that makes them? We don't know. Third thing is, it depends on how we want to live our life. Do we want to say, and I'm not saying go around shopping for doctors because, this, and I just gotta go find somebody that's going to cure me. I'm saying there's research that are showing us how we develop these conditions. And there's research showing what we can do about those conditions. And so if we're willing to take it up on ourselves, that we're willing to make a difference in our life. Because by taking control of your health, you take control of your destiny. And that's important. It can be complicated and it can be overwhelming. And working with somebody to get there is valuable to get there. They keep you on track because these things, how many of us have stayed on a diet, right? But the good thing is it can be done. The decision, is it right for you? Does that help? Thank you very much, everybody.